Good morning, future radiographers. Welcome back to Diagnostic Imaging Academy. Before we begin today's clinical case, take a moment to settle in, because what you are about to learn is not just theory. It is real-world diagnostic imaging practice that directly affects patient outcomes inside a modern hospital environment. Today's focus is one of the most clinically significant lower limb conditions in radiography. A diabetic foot ulcer? A diabetic foot ulcer is never just a surface wound. It is the visible endpoint of a deeper systemic breakdown, neurological damage, vascular insufficiency, and long-standing metabolic disease. What begins as a small break in the skin can silently progress beneath layers of tissue. Without pain, without early warning, until it becomes a limb-threatening infection. And by the time it is noticed, the disease has often already advanced beyond the skin. Inside a modern hospital radiology department, every foot X-ray carries a clinical responsibility that extends far beyond the image itself. Because in diabetic patients, what we are trying to understand is not only what is visible, but what is hidden beneath what is visible. Peripheral neuropathy changes everything. When sensation is reduced or completely lost, the body's natural warning system fails. A patient may continue walking on an injured foot, may continue applying pressure on infected tissue, may continue daily activity while damage progresses silently. No pain does not mean no pathology. It often means the opposite. This is where diagnostic imaging becomes essential. Radiography becomes the first objective voice of the injury. It translates what the patient cannot feel into what the clinician can see. On the PACS workstation, a diabetic foot radiograph is never reviewed casually. It is analyzed systematically and clinically. Soft tissue swelling may represent early infection or cellulitis. Gas within soft tissues may indicate aggressive bacterial infection and possible tissue necrosis. Loss of normal fat planes may suggest spreading inflammatory processes. And cortical bone irregularity may be the earliest radiographic sign of osteomyelitis. Osteomyelitis is not a minor finding. It represents a progression from soft tissue infection into bone. And once bone is involved, treatment becomes longer, more complex, and significantly more aggressive. At this stage, clinical management may shift from conservative treatment to surgical intervention. Radiographic positioning plays a direct role in whether these findings are visible or missed. The AP, oblique, and lateral projections of the foot must be performed with precision. Each projection serves a distinct diagnostic purpose. The AP view evaluates alignment and overall bone structure. The oblique view separates overlapping structures and improves visualization of subtle cortical changes. The lateral view demonstrates soft tissue swelling, calcaneal involvement, and posterior structural integrity. Even small positioning errors can significantly alter diagnostic accuracy. Rotation can mimic deformity or high pathology. Incomplete coverage can exclude infected regions. Motion can obscure fine cortical detail. And underexposure can mask early bone destruction. Radiography is therefore not a mechanical task. It is a clinical responsibility. One that requires anatomical knowledge, technical precision, and constant diagnostic awareness. Radiation protection remains essential. ALORA, as low as reasonably achievable, guides every exposure decision. However, in extremity imaging such as the foot, diagnostic clarity becomes the priority. Because in diabetic foot disease, the consequence of missed pathology is far greater than the risk of radiation exposure. When the image appears on the PACS system, that moment is critical. It is not just image acquisition. It is a clinical checkpoint. A moment where image quality, positioning accuracy, and diagnostic adequacy are confirmed. Because if the image is inadequate, diagnosis may be delayed even when disease is present. Normal foot anatomy is defined by clear cortical margins, preserved joint spaces, and well-defined soft tissue planes. But pathology changes this gradually. Bone margins become irregular. Density becomes uneven. Soft tissue shadows expand beyond normal boundaries. And these changes are often subtle, but clinically significant. In diabetic foot disease, radiography is not about dramatic findings. It is about early detection. Small changes that can alter treatment pathways and prevent major complications. Because in clinical imaging, timing determines outcome. Early detection may allow conservative management. Late detection may require surgical intervention or amputation. This is why radiographers are not just image producers. They are part of the diagnostic chain. Their accuracy directly influences patient outcomes. And this is the reality of diabetic foot imaging. It is not routine. It is not simple. It is clinically sensitive, technically demanding, and diagnostically critical. If you are learning radiography, medical imaging, or clinical diagnostic science, understand this clearly. You are not just learning how to take images. You are learning how to detect disease before it becomes irreversible. If this session helped you understand diabetic foot imaging, subscribe to Diagnostic Imaging Academy. Turn on notifications for the next clinical case. Join this journey of real-world radiography mastery. Now answer clinically. What is the earliest radiographic sign of osteomyelitis in diabetic foot imaging? Why is oblique projection important in foot radiography? How does diabetic neuropathy contribute to disease progression?